One of the unique things about this program, it allows us to evaluate our outpatient programs as well. I'm going to invite up Bill Shutze, who's going to talk about the verification process and how it's applied to an outpatient setting. Bill?
Thank you, Dr. Ingleton, and thank you for picking this topic for the Crawford Forum this year. This is a great topic, and we're really glad to get the exposure. So my job over the next few minutes is to talk about the why, the how, and some aspirations. The why is there an outpatient program and why do we need it? The how is it different from the inpatient program that's been described? And then finally, let's talk about the aspirations for the outpatient program. So the outpatient space has been around for a long time, and there's been surgery in the outpatient space for quite a long time. In 2008, CMS made a rule change in how outpatient vascular surgery services were going to be reimbursed, which led to an increase in reimbursement and markedly drove a lot of peripheral vascular care into the outpatient space. As a result of this, there was a surge in the number of outpatient facilities performing vascular procedures. However, there are significant accreditation and regulatory differences between the inpatient space and the outpatient space. All of you are very familiar with the rigorous accreditation standards and regulations for our hospitals. However, in the outpatient space, in many areas, there's a large void and certainly less rigorous standards. There's no federal standards for outpatient care in the medical world in the United States. This is all done at the state level, so there's 50 different ways that this is being done. Many of this is being done by medical boards with extensive or very inextensive oversight and rules. Some of this has been taken on by the departments of health. There are states that have requirements for accrediting bodies to come through and evaluate medical care being provided in the outpatient space, and I've listed several of these here. The Joint Commission, Quad A, etc. But there are many states that don't require these. However, these are not quality programs. These are safety programs. And there's a large gap in really addressing the quality issue in the outpatient space. The last thing I'd like to point out is that anybody with a medical license can provide vascular care outside the hospital. Anybody with a medical license. So there's a real issue there. And you can see that that could lead to a lot of the issues. And it's no secret in this room that there's been a lot of criticism for care that's being provided in the outpatient space, right or wrong. If you go to the website for the Federation of State Medical Boards, there's a nice summary of what states provide guidelines over the outpatient space. And you can see that there's 45 regulatory bodies that do provide some rules, maybe not extensive, maybe extensive over the outpatient lab. And then there's 12 that regulate the ASCs but do not have any rules relating to the office-based lab. And then there's 14 that have no regulations at all. And this just relates to the medical boards. This does not talk about the Department of Health. So how do the SVS get involved in verification? Well, you can see that many OBLs sprang up in states that have no rules, as I mentioned. SVS leadership was actually approached from several states about concerns regarding this. Several were trying to institute their own rules, and we found that many of those rules really missed the mark, and none of them really addressed the quality issue. And as Dr. Sadawi has already gone over the history and legacy of this program as to how we got here, and as well as talked about the conversation, the potential partners that we could go forward with. And at the end of the line, we're here with the ACS as really the most trusted and valued partner who's turned out to be the best partner that we could have for this journey into the outpatient space together. The standards are on this website. At the end, I'll have a QR code that you can take a snapshot with your phone where you can download the standards for the outpatient space. These are the domains that are covered within the outpatient space in this program, and they're pretty much almost everything that is going to be done in the outpatient space, in the OBL or an ASC. As you can see, there's a lot of overlap between what can be done in the hospital and in the outpatient space as well. But this program is really about the third column on the right. These are the procedures that overlap, and these are the ones that are unique to this program. So how is this program really scoped? Well, different facilities are going to concentrate in maybe one area, like peripheral arterial disease or dialysis access or venous disease, or some may have a scope of practice where they're in 2 of these areas, and some may be comprehensive and provide care in all of those areas. However, as a facility undergoes its evaluation through this program, it will only be evaluated based on the scope of service that is being provided. So hopefully that'll clear up any confusion for people that have outpatient labs that are not providing care in all these 3 areas. What about the standards? How do they differ? Well, clearly there are some areas that don't overlap and translate from the inpatient to the outpatient. And I've listed these, like the ICU, blood banking, affiliated service lines, transfusions, protocols, and readmissions. And these are not part of the outpatient standards. The remaining standards that are shared between the inpatient and outpatient programs are identical. There's no step up, there's no drop off in the requirements when you move from the inpatient to the outpatient. They are identical. What about the application process? Is that different? Actually not. It's pretty much the same. You enter the portal the same way. There's a peer review questionnaire, a PRQ, that's slimmed down, just going over the standards for the outpatient. There's a virtual site visit. It's only 1 day. It's not a day and a half. And you do get a final summation report that's very extensive from the ACS quality program following your review. What are the differences? Well, the PRQ is shorter, and the site is completed in less than 1 day. Last thing I would say, I didn't include this in my slides, but registries have been a big concern about surgeons that are interested in this program. We accept any registry, whether it's your own registry or another recognized registry. It does not have to be VQI, although VQI is encouraged, but it's not mandated. So why? Why are we in the outpatient verification space? Well, as I mentioned, the states are asking for it, and if we don't, and CMS is asking for it. If we don't provide it, as has been mentioned by Dr. Sadawi, somebody else will, and we don't expect that it will hit the same mark that we can. This allows your facility to streamline its protocols and outcomes, measure those, and improve your care based on that. More importantly, being verified in the outpatient program certifies to your community, to your referring physicians, to everyone around you, that you are committed to high quality care and that you are providing that care and you have the infrastructure in place to do it, and you're reviewing your data and you're getting better all the time. This also leads to a leveling of the playing field nationally. This promotes a national set of standards for vascular care in the outpatient space. Let's talk about our aspirations. What we'd really like to see this program do, in addition to the things I've already mentioned, is reduce some of the accreditation burdens in the OBL. Can this program replace accreditation requirements that are already in place? This will also hopefully demonstrate to payers that a verified program is a high-quality, low-cost site for patients to receive care, and hopefully reduce some of the pushback that we've witnessed in the last 6 to 12 months from payers in covering care in the outpatient space. And lastly, perhaps a verified center could have reduced prior authorization requirements or have those eliminated completely. While I leave this QR code up for you to take a snapshot of with your phone, and I'd like to thank Dr. Eagleton again for putting this forum together, Dr. Coe for your leadership at the college and the quality programs, Dr. Sadawi for your leadership, and Dr. Darling for being an excellent partner as we work together to move this program forward. And I'd like to thank everyone that's contributed to this program's development. As you have seen from slides from the previous speakers, many, many people have contributed countless hours, times, and really great input into making this a great program. Thank you.